Good day to one and all. We've gathered here today to be a part of learnings from ADA. As of today, this is day 2 of our gathering or as part of the Diabetes Week. As the name suggests, this session aims a larger reach and to benefit those who were unable to be a part of this prestigious forum. The medical community has responded very positively to this initiative. We have nearly 4,000 registrations for this event. So that's proof enough to show the enthusiasm. So without taking much of your precious time, I'd like to call upon Dr. Amit Gupta to welcome the audience and to share the welcome address. Sir, over to you.
Thank you, Uma. And I would like to welcome all the attendees who have joined here on behalf of Diabetes India as well as IDF Southeast Asia. And we are thankful to Dr. Azad Khan, who is currently the chair of IDF Southeast Asia, Dr. S.R. Arvind, president of Diabetes India, and Dr. Bansi Sadhu, who is currently the chair-elect of IDF Southeast Asia as well as the secretary of Diabetes India. And myself, Dr. Amit, I'm joint secretary of Diabetes India. So, as you all know that recently, just last week, the ADA 84th scientific session, they concluded in Orlando. And many of the faculties like Dr. Supratik, who is here, Dr. Noel, who is here, we were all at Orlando, and we thought that it would be nice if we can bring some of the updates from the ADA and discuss with our colleagues back home. So this is a part of that series, and this Diabetes Week started yesterday, and it is going to continue for another week, and where we are going to take different topics every week and learn from the experts who themselves attended the ADA, and they themselves were either speaker or attending the meeting in a big way. So for that, for today's session, we have with us Dr. Supratik Bhattacharya, who is our moderator, Dr. Noel Baringo, who is from the Florida International University, and Dr. Anuj Maheshwari, you all know, the governor of American College of Physicians India chapter. So with this, I would hand it over to Supratik to introduce Dr. Noel, and then we can start with the proceedings. Thank you, everyone, for joining.
Right. Thank you, Dr. Amit, for setting the context of the meeting. And may I please request RX team to put the introduction slide up? So it's our absolute pleasure and privilege to have on board Dr. Noel. Yes, so he has received his academic training. I think that is there a technical glitch from the RX events team? Can you see the screen properly now? All right, perfect. So Dr. Noel has received his academic training at University of Kuopio, Finland, and Karolinska Institute, Sweden, and University of Zurich, Switzerland, and he had done his MD in 1999, Master in Public Health in 2001, PhD in 2006. He's been an adjunct professor in public health at University of Helsinki, 2009, and his research interests are prevention and control of hypertension, diabetes, cardiovascular diseases, tobacco control, and physical activity. He has worked as a consultant in non-communicable diseases for PAHO, the Ministry of Health of Argentina, Colombia, and Paraguay. He has published more than 140 scientific publications in peer-reviewed journals and 3 book chapters. Currently, Dr. Noel also works as an associate professor at Herbert Wertheim College of Medicine, Florida International University in US. And he's the current chair of the Faculty Senate. So once again, it's an absolute pleasure and privilege to invite you for this webinar. Over to Dr. Noel, please.
Thank you. Good morning from Miami, or good evening to you. Let me share with you my presentation. I first of all would like to congratulate Diabetes India for this really amazing initiative, having these updates. I think it's a great example how what your delegates who managed to participate at the ADA meeting, how you transfer the knowledge to thousands of health professionals in your country. I think I haven't seen that anywhere else. So I really congratulate this initiative because it needs a lot of logistics, but I know that India, you're high tech and you know exactly, do the things really, really well. So congratulations everybody, and thank you so much for being invited today. I also know that you have an important game in 1 hour and where you take on South Africa. So let's try to be in time that everybody can join the hopeful victory of India later today. So I'm gonna explain you, I'm gonna give you an update on exercise and diabetes and the lessons I've learned, like at the ADA meeting this year, as I'm work a lot in physical activity and exercise. So these are the meetings I joined or the sessions I joined. I think there are many excellent talks, and I'm going to focus mainly on the two most important talks that I participated. So just go a little bit back to Hippocrates many thousands of years ago. He said that if you could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have the safest way to health. So now the problem is how much is too little and how much not too much. So I think this is what we are trying to find out usually when we do physical activity research. So I'm gonna divide my talk into 3 parts. So first, briefly, the effect of physical activity and glycemic control on cardiovascular outcomes in diabetes patients in general. Then the lessons learned from the ADA 84 scientific sessions, and then how much I think this may impact the physical activity recommendations for your patients with diabetes. So the first part, I'd like to give you a brief overview for those who may be not too familiar with exercise physiology or how physical activity improves health, on how physical activity impacts the different parts of our body. And we know, for instance, exercise has an impact on the fat cells. It improves insulin sensitivity, decrease inflammation and fat mass. In the muscle, it increases glucose uptake, glucose and fatty acid oxidations, and insulin sensitivity. It has an impact on the liver by increase the insulin sensitivity, decrease hepatic glucose production, and triglyceride accumulation. It also has an impact on the circulatory system, in blood glucose, HbA1c, serum triglycerides, and free fatty acids, as well as decreased blood pressure. And another probably most important impacts is on the pancreas. It decreased glucagon production and increased insulin secretion and beta cell mass. So we see that some people sometimes think that exercise works through changes in weight, but it's far more than that. So the most important thing is impact 5 organs. And as we all understand about diabetes, it's probably pretty easy to understand how the benefit of exercise in patients with diabetes. So what are the lessons learned from the ADA 84th scientific sessions, at least as far as I'm concerned? Here we have 3 happy delegates of the ADA meeting. You may recognize some of them. So I wanted to know, the most important message ever is like, what's the time course of exercise effects? Time exercise with meals. So is it beneficial having exercise right after meals or maybe before meals? Then some time-specific exercise. And then what are the effects of persistence training on diabetes outcome in general? We know from a previous study about 10 years ago that how a 7-day physical activity program consisting of 45 minutes of physical activity may impact glucose levels during the week. So we know that postprandial glucose level are decreased if we practice regular physical activity. And this has been shown successfully by previous studies. So we know that actually if you're regularly active, that it has an impact on postprandial glucose. And this is what they like to achieve, not only in diabetes patients, but also patients or persons with prediabetes, with impaired glucose tolerance or impaired fasting glucose. So, So a sample access schedule, considering that the physical activity recommendations are 150 minutes of moderate intensity physical activity per week. So we could imagine as 2 schedules, considering that there should not be more than 2 free days in the week. So we shouldn't leave 3 days without exercise. We can leave 2 days without exercise, but not more than 2. So potential schedule could be like schedule A, we do 50 minutes of physical activity on Monday, 50 minutes on Wednesday, 50 on Friday. We have 2 days off the weekend, and we have Tuesday and Thursday off. Another way how to distribute the 150 minutes of physical activity per week is like having every day from Monday to Friday, 30 minutes of physical activity. This basically is what a lot of guidelines basically suggested, how to distribute the physical activity minutes per week. And it basically works. I mean, we would reach 150 minutes of physical activity. Now, however, if you have a look what happens, glucose post-meal exercise effect, and you're going to see it's transient. So this study basically compared in a study of 45 minutes of moderate intensity exercise after breakfast. So the impact on postprandial glucose levels. We could see that 45 minutes of moderate intensity exercise after breakfast had an impact on the post-breakfast postprandial levels. It significantly decreased the postprandial level of breakfast. However, later on, if you had lunch and measured the levels after lunch, we saw the impact of the breakfast 45-minute postprandial exercise did not have an impact on lunch. So it had an impact directly on the meal that we consume, but not on long term. So it vanished the effect. And this is probably also in the insulin production, we can see that after lunch, no more effort. So protects the right after the latest meal you have been eaten. And probably it's easy to understand considering how exercise works in the different ways in our body. So a study tried then to evaluate in older adults, older than 6 years of age, 10 participants with BMI of below 35 and impaired fasting glucose. They had them going through 3 randomly ordered exercise protocols spaced 4 weeks apart. So they want to know what will be your postprandial level 15-minute walk after each meal, so breakfast, lunch, and dinner, or for instance, a 45-minute 2-hour post-meal walk in the morning, or a 45-minute walk 2 hours after the meal in the afternoon. They want to see whether there are any differences in postprandial levels. So what they first showed is that the 3 times 50-minute post-meal had a big impact. These are the control days in gray, and in black are the exercise day. So they saw a reduction of postprandial glucose 3 hours after lunch and 3 hours after dinner that persisted with the 3 times 50-minute post-meal walks. The 45-minute walk at 10:30 in the morning had a reduction in glucose, however, had no impact afterwards, the 45 minutes at 4:30. For the postprandial 3-hour glucose level post-dinner, actually was observed naturally the morning walk didn't have any impact anymore on the dinner. And the most important thing is that the 3 times 15 post-meal values, they decreased. So they showed an impact, a positive impact if you practice after every meal 15 minutes. When they compared the 24-hour average glucose level, they saw that 45 minutes at 10:30 decreased your average glucose level. So it has somehow an impact on the 24-hour average glucose levels. The 45-minute walk at 4:30 in the afternoon did not have an impact. However, the biggest impact or changes were seen that if you practice 3 times 50 minutes post-meal walks after your lunch. So they concluded that both sustained morning walking and post-meal walking significantly improved 24-hour glycemic control compared to the control days. And they also stated that post-meal walking was significantly more effective than 45 minutes of sustained morning or afternoon walking in lowering the 3-hour post-dinner glucose between the control and experimental days. So this is probably one of the most important messages I learned at the meeting. So coming back to our sample exercise schedule, so we could, for instance, decide, all right, let's do 45 minutes, 3 times 50 minutes post-meal walks from Monday till Friday. So after every meal, we're gonna go walk 15 minutes, and this is definitely gonna have an impact on our postprandial values or 24-hour glucose values, and probably gonna be have the most important impact on our patients' glucose levels. Again, Saturday, Sunday, you're gonna have free, you can do whatever you want, but it will be sufficient having Monday to Friday. However, if you use this schedule, then we're gonna end up with 225 minutes of moderate intensity physical activity. It's more than 150 recommended, but it's the healthier choice. If you still want to go back to the 150 level, we could maybe do this. We could have post-meal brisk walk at least twice per day. So we can have them after breakfast. That's the breakfast post-meal walk apparently is better than the later walk. And maybe the other one after lunch, or then you can choose after dinner. So with this regime or this schedule, we would end up with 150 minutes of moderate intensity physical activity per week. And you're still going to have a positive impact. So it's probably a good idea to split the 30 minutes daily physical activity into 2 different boosts of 50 minutes after the meals to improve the benefit in our metabolism. It was also presented whether what's better, morning versus evening training in general. And there was a study by Sean about 4 years ago presented that the screened 47 people, included in the end like 40 people that were randomly allocated to a morning physical activity or exercise intervention group and the afternoon exercise intervention group. No patients withdrawn, they all finished and they're included in the analysis. And what they basically showed, as you can see on the right side on the panel, actually there were no differences observed. So morning versus evening exercise were not associated with glycemic benefits or alterations in circadian rhythm when performed 3 times per week. So they concluded that it doesn't really matter if you do morning versus evening exercise, because there has been a lot of studies trying to associate whether it matters at what time of day you practice physical activity. So the summary of their talk was that the time course of exercise affects that with sufficient duration intensity, you have acute and persistent effects, increased skeletal muscle insulin sensitivity. With time exercise with meals, even shorter durations and moderate intensity transiently blunts glucose excursions. So they recommended after every meal 50 minutes of moderate intensity physical activity. And also in regard to time-specific exercise training, both are effective, morning and evening training. There's not much evidence whether morning is better or evening is better. So whenever you have the time to practice physical activity, if you don't want to do 50 minutes post-meal walks, you can choose morning and evening, whatever fits better into your schedule. What about resistance training? So how much does resistance training reduce HbA1c? Because remember, not everybody maybe is able to aerobic training. Sometimes resistance training is a better choice. So we would like to know the independent effect of resistance trainings. There are 2 large systematic review and meta-analysis that dedicated themselves to establish, to analyze, investigate the matters. And the meta-analysis basically of randomized control trials showed that HbA1c on average reduced by about 0.4% by resistance training alone. Greater reductions were observed with higher baseline HbA1c with intensity of about 70 to 80% so it's between moderate and high intensity, if the durations of the program is at least 12 to 16 weeks. So for longer durations, more impact, and for frequency, 2 to 3 times per week of resistance or strength exercise. Also, the optimal doses or frequency was like 3 sets per exercise, 8 to 10 repetitions, which is, if I remember right, more or less the common standard in most gyms that do resistance trainings. So higher strength gains were also associated with higher HbA1c reductions. A recent study that was conducted by Wayne, published this year, they showed the impact of resistance training combining aerobic exercise. So what this figure shows you is the impact of moderate intensity physical activity, which you have here in the bottom of the line. So we have 0 minutes of moderate intensity physical activity, 1 till 50 minutes. And here we start having the recommended level of physical activity. And the different dots are for different regimen or schedules of muscle strengthening activities or resistance training. So this is aerobic training combined with resistance training. And they showed actually impact that if you get up to 150 minutes and add resistance training, you have the largest decrease with about 150 minutes of moderate intensity physical activity combined with at least once per week of resistance training. Reductions also found in rigor mortality for 2, 3, or 4 times. But you see, when you add it the 4th time, the 4th day, it does not have that much additional benefit. Even once per week resistance training has a big impact on all-cause mortality when combined with moderate intensity physical activity. The 0 times, if you do not have any physical activity, aerobic activity, and do strength training, there was no benefit of strength training alone. in regard all-cause mortality. So it has to be combined with moderate intensity physical activity. A similar pattern was observed with those who have vigorous physical activity. You can tell your patients that moderate physical activity is when you can talk with someone, when you go jogging or walking, but you cannot sing anymore. If you can't sing and talk, then it's more or less a vigorous level of physical activity. But a very similar picture showed that the biggest benefit of those between 75 minutes and 150 vigorous physical activity, which is the recommendation in regard intensity, and combined with at least once per week resistance training. So these are the biggest benefit observed. So putting this all together, so how does the physical activity recommendations maybe change or updated or benefit from what I've shown? First of all, the current evidence still regular aerobic exercise training improves glycemic management in your diabetes patients. High intensity resistance exercise training has greater benefits than low to moderate intensity resistance training. Important thing is that resistance training at least once per week further improves your diabetes related outcomes in long term. So I think that's important to your patients to tell them combine aerobic with resistance training. We know also greater energy expenditure post-prandial reduced glucose levels, regardless of the exercise intensity or type. 15-minute post-meal walks blunts glucose excursion. So my advice to your patients would be that try to divide the 45 minutes of 15-minute boost like after the meals. That will have probably a bigger impact on postprandial glucose. And this is in line with the small doses of physiotherapy through the day. It breaks up sitting modestly and attenuates postprandial glucose and insulin levels. For reductions in visceral fats in patients type 2 diabetes, you need a moderately high volume of exercise, and this you definitely need to practice every day of the week in order to have change in visceral fats, which is a little bit more difficult to achieve. Then finally, that your patients type 2 diabetes using insulin secretagogues, they should probably supplement their activities with carbohydrate or reduce insulin, as you need to be careful to prevent hypoglycemia during and after exercise. Also, in bariatric surgery, it has been shown that an exercise program before bariatric surgery may enhance surgical outcomes and adds additional benefits for your patients in regard maintaining weight after surgery. To finalize, I think the adaptation of physical exercise variables to the patient's clinical needs, disease-specific symptoms, also have a look at the personal preferences, time availability. I think these are very important factors to maintain a long-term compliance to the exercise program. And it also includes that you prescribe exercise to patients, and a lot of evidence-based programs, how you can do prescription of exercise to patients, and using the prescription practice and organizing your team to routinely advise every patient you have with prediabetes, diabetes, even people at risk to practice physical activity, gonna have an important impact. So finally, more is better than less, but something is better than nothing. And this is the important thing in regard to physical activity. So I really thank you and everyone for this opportunity of talking to you, to so many people. This is a picture of our interest group. So at ADA, we have the Public Health and Epidemiology Interest Group. I'm the past chair. We have Dr. Gupta. He is the chair-elect. So in 2 years, take over the interest group. And if you'd like to join a great interest group, make sure it's ours. And if you'd like to know more about what I'm working, you have here my Facebook, my Instagram information, my Twitter, and I'm more than happy to provide more information if you contact me. Thank you so much for the opportunity, and I hope that this was useful.
Fantastic talk, Dr. Noel, and again, congratulations to you and also Dr. Amit for the upcoming responsibilities that he is going to have from this interest group. I think we're going to do the question and answers at the end of the two talks, if that's okay with you. We have Professor Anuj Maheshwari joining us today, and I'd be introducing him for the next talk. And once we are done with both the talks, then we'll take up the question answers. So he's a very close friend, my mentor, and he's presently the governor, ACP India chapter. But can we have the introduction slide on board from the RX events team, please? So once again, a pleasure and privilege to introduce Professor Dr. Anuj Maheshwari. He has been the past vice president of RSSDI, governor of the American College of Physicians India chapter. He is the professor in the Department of Medicine, Hind Institute of Medical Sciences, Lucknow. And he has been a PhD and DNB teacher and guide for the last 12 years. He has got 87 papers and more. It's counting, and in international and national journals, and 64 publications on diabetes, hypertension, and its complications in index journals. He has also received the R.J. Wegman Oration by the Indian Society of Hypertension in 2015. He has been awarded the B.C. Bansal Oration in Annual Conference in ISC in 2016. V.G. Nadgoda Lecture in RSSDI 2016. Professor P.R. Prasad Oration by RSSDI Jharkhand chapter. Dr. R.M. Shah Oration by RSSDI Gujarat in 2018. It's been invited for the Kurukwa Oration in ACP Japan chapter in 2019 at Kyoto University, and Sanofi Lectureship in Diabetes by Epicon 2020 at Agra. He's also the recipient of 2018. Okay, so he has got many prestigious awards and orations to his name. And once again, it's an absolute honor to have you on board, sir. So over to you for the oration.
Thank you. Thank you, Supratik, for the kind introduction and kind words for me. Thank you, Amit, for including me this in today's program. And thanks, Dr. Bansi, for always being very kind and very caring. I'm sharing my slides. I think visible.
Yes, it's visible, sir. All you need to do is make it full screen.
Yes. So is it visible?
Yes, perfect. Thank you.
So it's really going to be pleasure to discuss few of the learning which we could recollected from the ADA recently concluded ADA conference, hypertension and lipids. I've been given this part. So I shall be telling you few very interesting studies which has been discussed there and have been presented there. We all know about that family history is one of the integral part of the diabetes, hypertension, and dyslipidemia. All the three diseases are associated together. They are arising out of the same soil, and most of the time they are also having the similar level of the similar kind of the complications also. So what exactly happens when we are talking about one disease, the remaining two diseases always come one by one or one after each other if they are not well managed. So there has been a very interesting study presented by the Japanese authors in which they screened about the 41,931 individuals about the family history and its impact on these three diseases. They have taken up the family history of the father, mother, sibling, and grandparents. And this cross-sectional study showed that odds ratio increased with the degree of positivity of the family history for all the three diseases. Means whatever the generations are more involved at the same time in family, 3 persons are diabetic, 4 persons are diabetic, means the chances of getting diabetes into the next generation and next relative would be much more higher. So a lot of idea we were already having, but they have given the quantified idea about this type 2 diabetes group with 3-generation positive family history was approximately 20 times larger than control with no family history. In the longitudinal study, the family history had a strong influence on the incidence of type 2 diabetes, hypertension, dyslipidemia, with the hazard ratio of 2.4 for type 2 diabetes. It means, again, this was having the highest impact on the occurrence of type 2 diabetes. So when we always say that type 2 diabetes, hypertension, and dyslipidemia is arising out of the same soil. Hypertension is having 3 times more prevalence than diabetes. Dyslipidemia may be having the 4 to 5 times more prevalence than diabetes, but still the severity and adverse outcome are always associated more with the diabetes. Detailed family history is extremely useful for both quantitative screening for each disease and predicting their incidence, especially type 2 diabetes, for which a high risk is indicated in multiple generations with overlapping positivity for a particular disease. So let's discuss another very interesting disease which have been presented in ADA, in which they discuss about the remission of diabetes. We always say that these 3 diseases are always run together: diabetes, hypertension, and dyslipidemia. Do it really be ever seen that once the remission of the diabetes is occurring, the remission of the hypertension and dyslipidemia is itself occurring with the remission of the diabetes? So coexistence of these 3 diseases is well accepted, but do we find ever the similar trends in their remission also? 2,630, very robust data, in the Japanese patient with diabetes, those who were having HbA1c more than 6.5. And remission, they have defined remission as HbA1c keeping less than 6.5 for at least 3 months or more, blood pressure keeping less than 130 at least 3 months or more, non-HDL cholesterol less than 150 and HDL cholesterol more than 40. If these 4 things are there, they told the patient as in the remission. Let's see what was the what they really observed in their study. Among the type 2 diabetes patients, they found that those who had the remission of the diabetes did not have the same level of the remission in hypertension and dyslipidemia. All those patients who have been in the remission with type 2 diabetes, only 26% achieved remission in hypertension, and only 26% achieved remission in dyslipidemia, and only 8% were there, those who could achieve the remission in both these diseases, hypertension and dyslipidemia. The BMI remission was the common factor in these kinds of the patient. People, those who could done their remission of the BMI, they have really did the wonderful remission in all the 3 diseases. So now we can understand obesity is playing the master role in all these 3 diseases and their progression, remission, and leading towards a complication. There has been another study which has observed about the obesity and compared its risk as a risk factor with the heritability. Heritability and obesity are strongly associated with these 3 diseases, what we call as diabetes, especially I'm talking about the type 2 diabetes, hypertension, and dyslipidemia. About 41,931 patients compared the effects of the family history on these 3 diseases with obesity on the prevalence of each of them. Odds ratios increase for all the 3 diseases as the number of family history positive cases increased and was most pronounced for those with type 2 diabetes. A family history of obesity and increased BMI were additively associated with the prevalence of 3 diseases compared to low BMI and no family history. For type 2 diabetes, the odds ratio increased sharply even in non-obese participants. I'm taking it specifically here. In non-obese participants, when the number of those with family history more than 3 as compared to those who were obese, when number of those with family history was 2. So family history was equally important tool for the determination of progression of the disease as well as how fast it will lead to the complication. Now we talk about much about the GLP-1 receptor agonist, and it is said that GLP-1 receptor agonist helps a lot in remission of diabetes. Does it really helps in the remission of other two things which are associated with the diabetes or additive with the diabetes, like hypertension and dyslipidemia? GLP-1 receptor agonist helps in reducing risk of hypertension in animal model. This has been proven by determining cardiomyocyte size and cardiac fibrosis, which has been detected by the MT staining and collagen level detection, and highlighted the cardiovascular benefit. So it is not actually the indirect effect, just insulin resistance is going down, just diabetes is coming down, or patient is losing the weight and hypertension is controlled. This has been demonstrated even in animal model in the rats that GLP-1 receptor agonist is not only helping in reducing insulin resistance and weight, but also it is helping in cardiomyocyte size reduction and reducing in the cardiac fibrosis, to which it is most beneficial for the cardioprotection, and its cardioprotective effect has been compared with simultaneously in another arm, the tirzepatide, and tirzepatide has been taken as a control in the study. It has been found that GLP-1 receptor agonist has more potent cardioprotective effect as compared to the tirzepatide in hypertension-mediated cardiac damage. So this is a very important information what we could really achieve from this ADA. Of course, we all know about the beneficial effects of the finerenone. It has been recently introduced in our armamentarium or in our tools of the diabetes management, management, in which we can reduce the progression towards the kidney disease in a patient of the diabetes. In per se, it does not act directly on the diabetes, but it helps in reduction the complication. What is seen here? This was the Indian study. In Indian population, about in 84 number of the patient, 42 has been given the finerenone, and remaining 42 has been given the other alternative for control of the blood pressure. What we could see, these 84 patients, those who were having the resistant hypertension, finerenone brought significant decrease in the systolic blood pressure from 22 to 12 mm of mercury, which was a significant p-value, and diastolic blood pressure also from 12 versus 4 mm in 2 months of the treatment. 10 milligram of the finerenone, 2 months, it brought down the significant drop in the systolic as well as in the diastolic blood pressure in resistant hypertension. The more important in the resistant hypertension. Resistant hypertension means the people that were already taking the 3 medications in their full doses. 78% patients in finerenone arm and 46% patients in alternative arm were found to be controlled, keeping their blood pressure less than 130/80. So this is again a very significant, highly significant, because these 46%, those who were using the alternative arm, they were also using the antihypertensive medication, but that medication was not that much effective as the finerenone was, almost double effective, you can say. Double number of the patient could get the remission of the hypertension. So conclusion, 10 milligram finerenone was effective in reducing BP up to optimal level in type 2 diabetes Indian patient with resistant hypertension, well tolerated, no significant concern of the change in potassium level. So similarly, another very interesting work has been presented in ADA, in which it has been shown whether bariatric surgery had an impact on hypertension and diabetic kidney disease in patients with type 2 diabetes. We all know that it works on the type 2 diabetes, it works on the obesity, but does it really work on the hypertension, and can it really reduce the progression towards the diabetic kidney disease? For that purpose, the researchers has used the pigment epithelium derived factors at baseline. It predicts onset of the severe albuminuria and hypertension over the 15 years. This pigment epithelium derived factor has been found decreased after the bariatric surgery when the follow-up has been done at 6 months. In due course of the action up to 5 years, shown durable attenuation of the plasma level of the pigment epithelium-derived factors after metabolic bariatric surgery. And this PEDF is a protein which is strongly associated with the risk of severe albuminuria and hypertension in patients with diabetes, especially the type 2 diabetes, even in their young age. And this PEDF is implicated in endothelial dysfunction and vascular damage, though impaired angiogenesis and endothelial repair mechanism were there. So we all know that endothelial dysfunction is the first step of atherosclerosis or cardiovascular adverse outcome, what starts about 10 to 15 years of the diagnosis, 10 to 15 years before the occurrence of the diabetes or diagnosis of the type 2 diabetes. So another study in which it has been seen whether the blood pressure variability or sudden rise of the blood pressure is having any say on the and whether it is associated with the catecholamine blood pressure surge. It has been checked through the carotid baroreceptor magnetic stimulation, which increased actually the nitroprusside vasodilator effect that acts as a nitric oxide donor, suggesting baroreflex to improve vessel sensitivity to nitric oxide mediated dilation, which is impaired in the diabetes, being a new physiology with blood pressure buffering results. That's why in most of the time, it becomes very difficult to treat hypertension in patients with diabetes. Rising blood pressure variability is suggested to be a diagnostic tool for diabetics, especially for the diabetic susceptibility to morning surges, which is linked with the major macrovascular event. In morning surge of the catecholamine, which is actually responsible for macrovascular events which are occurring in the early morning, maybe stroke, maybe MI, occurring together with the sudden rise of the blood pressure. Let's few words about the lipid learning in ADA. Miami Heart Study insights has been presented there, in which it was seen that nearly 1 in every 3 individuals with diabetes, even they are having the coronary artery calcium score 0, had coronary plaque, and 3% had stenosis. More than 50%, however, no follow-up data available. What if no CAC on CT, coronary artery calcification, is not there? Do we really treat them for dyslipidemia for the statin with the statin? Or if yes, then how long is the warranty period for the 0 CAC score if it is found to be safe towards the cardiovascular obstruction or adverse outcome? Potential for the plaque imaging with the CTA and helping with personalized cardiovascular risk assessment has been sought. And what we could really see here, the CAC score of 0, if a person, even if the person is having the diabetes duration less than 10 years, is still there more than 1, and we can see that time to coronary artery disease, although it is the least, but it is still working there towards the progression for the coronary heart disease, and cumulative coronary heart disease free survival is the maximum, but again, it is not completely safe. So even if the CAC is 0, we should treat the patient with the statin therapy in setting of the type 2 diabetes. Time to acute MI for patient with yearly change in calcium volume score, which is more than 50% or less than 50% according to the baseline calcium score. Now, question arises, what should we do for the screening for non-obstructive CAD while on treatment with statin? Already patient is taking the statin, there is no obstruction in the coronary artery disease. Do we really have some screening for them? Of course, we should do the CAC screening for them. We should look for the CTA plaque, and inflammation markers should be sought. Progression of the CAC was significantly greater in patient receiving statin who had MI compared with event-free subject despite similar LDL control. Continued expansion of the CAC may indicate failure of some patient to benefit from statin therapy and an increased risk of the having cardiovascular event. what we could see in, although this is a well-known fact and previous study which has been published already in the JAMA in December 2017, which was presented by some speaker, is showing that if the diabetes is there, the risk is the maximum for the coronary artery disease. CAC score is the highest in the setting of the diabetes, which is not even in the setting of the metabolic syndrome. And if it is no diabetes, no metabolic syndrome, the risk is the least. In diabetics, those who are having in diabetics patient, when they have been compared with the non-diabetes in each CAC category during a follow-up of 5 to 8.5 years, had higher all-cause mortality. So there are the evidence which says that presence of coronary artery calcium from the imaging modality, the most evidence present extensive CAC deposits in majority of the diabetes patient. 25 to 39% of the diabetes had no CAC independent of the duration of diabetes. More presence of the CAC adds incremental prognostic information to traditional risk factors. Higher CAC, worse prognosis, no or low CAC having the comparatively better prognosis. In such setting, more than 2% event rate in the diabetic patient with CAC ranging between 0 to 10, similar to the non-diabetics. So, detection of the silent myocardial ischemia in asymptomatic diabetic subjects is again a very, very tricky thing. Most of the diabetic patients get the silent MI and they remain asymptomatic all the time. Even if they develop MI, they don't develop any symptom. 1,123 patients with type 2 diabetes of the age 50 to 75 years, 5 years follow-up has been done in 2 arms. In one arm, they have been kept on the stress testing, and the other arm, they have not been done the stress testing. Silent ischemia identified in more than 113 patients, it was 22%. Moderate or large perfusion defects were present in 33 patients. In total population, a low cardiac event rate was noted, which was 2.9% in 4.8 years. No difference in the primary endpoint of the cardiac death or non-fatal MI noted between the two groups. Certain guidelines which says that in presence of the diabetes, cardiorenal and metabolic disease, CAC score, atherosclerotic cardiovascular disease risk are the more important and more reliable tools for the measurement of the risk. So finally, what did we learn? Fewer patients than expected were found to have obstructive disease. There was no outcome benefit from revascularization in the presence of obstructive disease if patient is asymptomatic. Significant improvement in both blood pressure and lipid panel targets, severe achieved among those recommended for aggressive risk factors education. LPA, which is another very important lipid marker, its levels are largely genetically determined. LPA is a causal and independent risk factor for the cardiovascular disease. The basis of the LPA pathogenicity centers on its pro-inflammatory properties largely conferred by preferential QXPL addition. Pharmaceutical approaches in development for the LPA lowering are focused on the inhibition of the production of the LPA, which includes ASO, siRNA, and small molecule. Phase 3 data from the LPA Horizon and Ocean trials will be reported within few years. The relationships between the low levels of the LPA and development of the type 2 diabetes remains an area of ongoing study, as well as the nature of disease in patients with established type 2 diabetes and elevated LPA. This slide I have included in my presentation just to give a clue to the researchers that they have the opportunity to do this work in their country. In next few years, we are coming up with a lot of data which would be related and comparing with the LPA in setting of the type 2 diabetes. So before I close, I must tell this saying which I have seen there. If access to the healthcare is considered a human right, who is considered human enough to have that right? This is really true for our country. Thank you very much for your kind listening.
Thank you, Professor Maheshwari, for an excellent update on both the lipids as well as the hypertension from the ADA. And there's a lot of learning that we had. We'll take a small break. I think RX Events wants to run a video. So once we are done with that, we'll take up the question and answers.
Continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time I can. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan. SanoCare, caring for love.
All right, thank you. And we are back. Do we have Dr. Noel on board? Perfect. So I would request the team to post all the questions that we have from the delegates attending the meeting on the chat box so that, both our speakers have visibility of the questions. And while we do that, yes, Dr. Amit.
Yeah, first of all, I would like to congratulate both the speakers, Dr. Arush Maheshwari and as well as Dr. Noel, because they have really put in very hard work to gather all the information from the 84th scientific session, and it was a delight to watch both the presentations and very, very informative. And I'm sure all the viewers, they must be having a lot of questions. And I think even an hour is not enough for the discussion which is going to happen, but we will keep it short and simple, and so that, match is also coming up. Many of the people, they will be interested in watching the match also. Congratulations, sir, and congratulations, Noel, sir, for bringing this very best of the idea at this platform.
Very nice talk, Noel, you had done. I started
Me
join.
Me and Amit are the evidence, because we were knowing that how Anuj, going from one hall to other hall to gather all the information related to hypertension and lipid stock. One very, interesting and less discussed in India is lipoprotein little a. Most of the time, physicians, they don't understand the importance of it, as you are also the part of Lipid Association of India. And the second is, should it be done once in a lifetime or should we repeat it? At present, we don't have anything to treat it except the newer monoclonal antibodies which are available now to us. And is it for Asian, is it very more risky if you have a lipoprotein A which is higher? So what is your comments, Anuj, or any data or evidence which is coming from India also?
Actually, what I presented today, that was the data what has been presented in ADA. I, in fact, did not try to find the data from the internet, which has already been published in other places. But what the present information is there, ADA speakers has told that we had to get more information about the LPA. what I understand that we were also having this idea that once in a lifetime you can check the LPA, is not going to change much. But now the current evidences which are coming on the small studies, that they can be changed in their lifetime after doing control with the associated diseases, taking the treatment in the form of the present lipid lowering agent, because now we are having more lipid lowering agent apart from the statins. We are having we have PCSK9, we are having bempedoic acid, and lot of data yet to be. In fact, two big trial, as I mentioned in my presentation, they are yet to be finished in next 2-3 years, and then we can be having more clarity about the LPA. And no doubt, this is more detrimental factor for the for the Asian Indian population. But we could get the more information after finishing these trials. In the meantime, I wish that we Indian can start some study. That's why I put that slide in my presentation. I wish that researchers in our country can start multicentric study regarding the comparing the type 2 diabetes as an LPA level, and we can also come out with our own data.
Thank you, Dr. Anuj. May I now ask a question to Dr. Noel? Like there has been a lot of talk about this soleus muscle push-up, Does it really help in type 2 diabetes for those who are relatively sedentary, they're not getting time for actually going out and doing some aerobic exercises?
All right, thanks. I think if you have a look at the last study I showed, the biggest benefit is basically achieved by combining aerobic with resistance training. So the study that last one I showed, against doing resistance exercise alone apparently is not sufficient. It has to be combined with at least some minutes of aerobic activity, even if it's 75 minutes. And that's at the moment what the most important studies show. Also, larger cohort studies, observational studies basically show the same, that muscle strength and activity alone, it's very difficult that they have a larger benefit in regard cardiovascular disease mortality, all-cause mortality, but when combined with aerobic exercise, the resistance training further increases and improves the health-related outcomes.
Perfect. So another sort of important thing that we face in our practice is that a lot of people are now glued to their computers. They're having long working hours because of the IT industry. So they complain that they don't have dedicated 15 minutes to spare to go out and walk. So in those scenarios, the short bursts of exercise, maybe like 5 minutes of brisk walking, coming back and sitting in front of the computer, does that help at all at regular intervals?
Yes, I mean, the latest studies have shown that the WHO guidelines that you can accumulate minutes. You can have boosts of 5 minutes, 10 minutes is perfectly fine, as long as you get to 150 minutes. And I understand sometimes during work, it's very difficult to do physical activity, but then you can get the boost also in a while to work. Like, for instance, you can leave the car somewhere else or walk in the last few blocks using the stairs when you go to your office. A lot of different forms you can get your boost of physical activity, like in your daily work, in the morning, before work. If it's during the work, if companies would understand the importance of having physical activity breaks, that will be great. You can do a lot of exercise with your chair in your office. And through the American Public Health Association, we once run a lunchtime meeting, a half an hour, physical activity sessions for people at work. And I'm more than happy to share the video. So these are some activities you could do actually at work or while you're working. And I guess you have like coffee breaks at one point, and this can be used maybe to do a physical activity break. I think it's all about seeing how to fit in time. I think it's making the time and knowing how to do it.
Perfect. So I'll come back to you in a minute. Dr. Amit
So
wants to...
Yeah, I just wanted to highlight one thing. If you, as we all know, that for the last couple of days, one of the paper is doing rounds in India, and it is about a Lancet study that talks about that some of the survey done in 2022. It says that more than 50% of the Indians, they are physically inactive, and the physical inactivity is even more in females than in males. So this again points out to a very huge burden of physically inactive people in our part of the world. So, would you like to add anything to that, especially Dr. Adit Maheshwari sir or Dr. Noel?
I think that's a good comment. So population surveys usually tell you that helps to survey like the physicality levels, but I think there are a couple of ways how to improve physicality in the population. You have the population approach that are by physicality guidelines for the countries, facilitating the opportunity, the potential that people can physically be active. This has to be environmental planning. It also has to start very early at school, the earlier possible. I mean, I could talk about 3 hours about that. So just in brief, it needs the population approach, but also the high risk approach within primary healthcare, within where you can work with your patients, assessing whether patients are physically active or not. And if not, working maybe the physical activity prescription, as patients like prescriptions. And there are enough models like that, physical prescription, they work. So I think we could have an own session probably on how to increase visit in India in near future.
I'll come back to you, Dr. Noel, and just in the meanwhile, Professor Maheshwari, I want to follow up with what Dr. Bansi had been talking about. So there is a residual risk that remains if you're targeting only the LDL and not addressing the non-HDL or the LPA. There's a residual risk that remains. And at the moment, we don't have, very definite treatment to address that residual risk. Now, we are having some interesting researches that are coming up. Maybe some novel agents are going to come up in future, which is going to address that. Meanwhile, what are we going to do that? So now should we start looking more into the non-HDL and not just the LDL, because there's no clinically proven, data suggesting that all the data that we have accumulated in terms of cardiovascular risk reduction has been in terms of statins lowering the LDL. So what should be our way forward? Should we be addressing the non-HDL and this LPA and the residual risk more often now, especially for a diabetic population?
In fact, Supratik, we all know that even after giving the full treatment of the statin and maximum possible dose of the statin, still our patients carry some residual risk. And that residual risk is enough to cause any myocardial emergency or a stroke to them. So this risk always there, even if we are giving the statin. Obviously, statin reduces the risk, but it does not completely eliminate the risk. Same way, so what we really need to do, we actually right now also do the same thing, that patient should be kept on continuous surveillance. Patient should be advised to keep on doing the regular lifestyle modification, continue statin, never stop statin, even if the lipid level is even LDL level is going beyond 30 or below 30. Many people try to stop the statin. Statin should not be stopped even in that condition. It should be always up titrated up to the maximum tolerance dose. So these things, these are the basic things what we can take in our preventive armamentarium. Then question arises, if there is an obstruction, if there is any obstructive disease, definitely there is no other way to remove that obstruction. We need to remove that obstruction either by CABG or by the angioplasty or whatever way. But nowadays, as I have already shown in one of my slides, many patients are presenting with the non-obstructive disease also. In those conditions, non-obstructive disease, LPA level is high, patient in the high risk zone, although non-HDL has been well maintained, you have corrected the hypertriglyceridemia, you have corrected the diabetes, you have kept your blood pressure also up to the level where it is desired. But you never know that when it will come back, when the surge will come, and when the episodic hypertension may arise. So these are the gray areas which will always exist. Even if we get some sort of therapy for the LPA also in near future, even if we get some remedy for the LPA, still these gray areas will persist. After all, death also needs its way out. Somehow the person has to die. So there would be these gray areas which will be the mediator for the ultimate death of the person.
Thank you, Dr. Maheshwari. I'll now go back to Dr. Noel again. Again, a practical question. So we know that, with the elderly population, there is always a concern with the knees, and they have problems doing exercises. And many of them do have, treadmills at home. So do you recommend that they should be walking on flat surface rather than using the treadmill, which is going to, affect the knees more? Or is it not a concern for them? It's just something that, they sort of presume that it's a concern, but it's not that a big concern for them. And second part of the question is that hydrotherapy, for those with knee issues, does it really help in terms of, the benefits that we had been talking about? Is it similar to the aerobic exercises?
I think, yes, it matters, because if an older adult, even can be a younger adult, has like knee pains, it's serious, and it usually restricts the patients to physical activity. I mean, we know from our own experience, if you have pains, you usually don't do that practice, right? So, but there are other forms. I mean, usually if you have treadmill bicycles, it's usually, if it's supervised bicycle training, it usually doesn't impact that much your knee joints. And I mean, unless, depends on what knee problem you have, right? So there's probably certain forms of exercise you can't do if you have knee problems or hip problems. But I like the second part of the question. Yes, exercise you do in the water. You can do swimming. Swimming is very healthy for your joints, but of course you need to have the access to a pool where you can practice it. If you've ever tried hydro exercise, it gets aerobic. So it can do a lot of forms like water, aerobics, whatever. There are aerobic activities, and I really invite everybody to try to join it. You're going to realize you're going to breathe, and it's considered aerobic exercise. I think everything in water helps a lot for people who probably may have problem with overweight or obese and who have knee problems. Of course, it has to be in safe conditions and supervised, but I think it's an excellent form. And that's the main point. We have to try the perfect form or type of physical activity for our patients that they're motivated and they like to do, and that's safe for them to do. And I think that's usually the challenge. It's not enough just telling them, we go to walk for half an hour, but maybe they really hate walking, and let's find something they like to do. Like we had a study in northern Colombia, Barranquilla. It's also very humid outside. People don't go to walk. So what we tell them, they love to dance, and okay, dance for half an hour per day, and they loved it because everybody likes to dance. And if you do dancing, it's aerobic. I remember from Diabetes India in February that when we were dancing to the concert we had.
Thank you, Dr. Noel. And Dr. Amit, do you have any other questions, or can we conclude?
Yes, so Pratik, we don't have any other question, and I think it was a fantastic session. So we can conclude now. I know Dr. Anuj is also traveling, and he has, despite his busy travel schedule, he has taken out time and prepared slides on such a short notice. Noel also just 4 days after the ADA. And it's not an easy task.
Big thank you from our side, and I think Dr. Amit is going to do the official Thanksgiving.
Few words that this meeting, which we are doing under the banner of Diabetes India with the support of IDF, just to inform of the audience that we have this year our Diabetes India meeting at Ahmedabad in month of Feb. And we also have IDF Southeast Asia Congress along with RSSDI in month of November at Delhi. Just to inform all our audience, and this meeting we are doing every day with the learnings of ADA with all the experts who were there in ADA. So I'm thanking all the experts, Dr. Noel and Dr. Anuj for today's meeting, along with Dr. Supratik and Amit. With these words, I'm thanking, and now over to Supratik for final vote of thanks. Thank you.
Right. Thank you, Dr. Bansi. You have been instrumental with Diabetes India, and you have a great team with Dr. Amit on board, and everybody in Diabetes India are very, very enthusiastic and regarding academics. And it's a welcome opportunity for all of us to be connected and to update everybody regarding all the recent updates that we had at ADA. And a big thank you to Dr. Noel and Professor Maheshwari for joining us today with the latest updates. And they had worked so hard in this regard, and it's really appreciated. So once again, Dr. Purvi is on board as well. And the entire team of Diabetes India, a big congratulations to all of you. And those who had joined us as delegates, hope it had been useful for you. So once again, a big thank you and a good night from our side.
Thank you.
Thank
Thank
you.
you. Good night.
Honor
Bye-bye,
for me.
everyone.
Enjoy the game.